to review some selected cases, and we do have a poll question for our lovely audience. So at Blackpool, we started the drug Vabysmo somewhere in 2023, and since then we have increased our usage. On an average, we do 1,000 injections per month, and currently Vabysmo has taken approximately 50% of the total injections that we do in Blackpool. Most of our neovascular patients are naive patients, and 40% of our patients are switch patients. So let's look into our case number 1, which is a resistant CNVM, which had a delayed switch. This is a patient with left wet age-related macular degeneration. Started treatment somewhere in 2018. Over the years, she went on to receive 17 Eylea injections and still was pretty much active. At this point in 2023, she developed a rebleed, and we did have this drug. And this is after 3 loading doses of Vabysmo. In this patient, we did achieve a good anatomical outcome, but unfortunately, this did not correlate to a good functional outcome. On contrary to our first case, let's look into a case which had an early switch. Patient with left wet age-related macular degeneration goes on to receive 6 injections of Eylea, still pretty much active. At that point in time, we did consider an early switch. This is after the loading doses of Vabysmo, and you can see that the retina is very well dried. And this good anatomical outcome did correlate with a good functional outcome for this patient. Our case number 3 is a treatment-naive bilateral patient with baseline visual acuity of 40 letters in the right eye and 45 in the left eye. These are the baseline OCT pictures and a beautifully captured membrane on the octa. This is after 3 loading doses of Vabysmo, and you can see that the PED has completely flattened out and the retina is pretty much dry. This did correlate to the visual acuity, and the patient gained approximately 70 letters in the right eye and 60 in the left eye. And drying effect. So this drug, we did find that it particularly dries up the retina pretty quick. So if you see this patient with right wet age-related macular degeneration with some SHRM and SRF, this is after 5 days after the injection. You can see a dramatic decrease in the size of the SHRM. And when we talk about durability, we are a pretty big service. We want a drug which was durable, where we can push the treatment interval somewhere around Q16 week. So again, this patient, Again, this is a left eye wet age-related macular the video is not playing up. Left wet age-related macular degeneration, fluid in all possible pockets. There's a baseline. This is after monthly doses of loading doses of Vabysmo. Retina is well dried, and patient was maintained on Q8 weekly interval. So this patient again had a very good anatomical outcome, but you can see some PEDs, they respond very well to this drug, but some amount of atrophy has already set in. And coming to, can we push the treatment interval? Yes, we can push the treatment interval. Most of our patients we have pushed beyond Q12 weekly interval at this point. This patient with left wet age-related macular degeneration, baseline visual acuity of 74 letters, goes on to receive 4 loading doses. After 4 loading doses is pretty much inactive, and this patient was on PRN treatment, and currently he's still dry and awaiting for YAC cap. So drugs like this, they are particularly very valuable in our service where we have capacity issues and capacity constraints at all times. So this was a poll question. Patient with left AMD started treatment in 2020, goes on to receive 6 aflibercept injections, moves on to 2021, further 6 more injections, still active. 2022, still active. 2023, still active, and still on anti-VEGF treatment. So what do we do for patients like this? Frequent flyers, recalcitrant. So this is the treatment options that we had. And at that point in time, we thought, let's switch the patient and see what happens. So we switched the patient, and the retina was dry for the first time. The SRF disappeared, and the PED decreased in size. So the take-home message is that we want our patients to have drier retina, and a shorter delay is better because you're going to get a good functional outcome. Having said that, a longer delay switch is also worth a try. Thank you.
Yeah, thank you so much. Great presentation. I think few points. I think you're focused on Vabysmo on in this talk, but it's not like this. We had patients who would respond very well to switching to Vabysmo, others who do not respond, and then would respond on Eylea HD, and again same thing. So I think we don't know like which patients responds to which medicine. So like Vabysmo is not the solution for everyone, and also Eylea HD is not the solution for everyone. I don't know if that's what you saw as well.
Yes, we do have 10 to 20% of the patients who don't respond.
Correct.
Yes, they don't respond, and switching them back and forth, we try to avoid that. But again, those 20% of patients are there for every hand to address.
Yeah, no, of course. But I'm saying, I mean, in the ideal world, we would know that, for example, this patient with this like phenotypical presentation from Blackpool or from, I don't know, Nuneaton or whatever, actually will respond to Vabysmo. The other patient from India, no, this is the Eylea HD patient, but we don't know that. Yeah. And I think also one thing is, which complicate matters, we're not getting FA and ICG on everyone now, and some of the cases might be IPCV. I think maybe probably case number 5 is probably an IPCV. So I think that complicates matters, so it just need to be taken in consideration.
Yeah. I think that's a very well noted point. So what we did was we looked into the OCT biomarkers, and we wanted to see which biomarker correlated positively and negatively. And of all the biomarkers, we found PEDs. If a patient has a fibrovascular PED, they tend to do better with this drug.
Yeah, that's a fair point.
Just a quick comment. Actually, we always talking about Eylea 8 milligram and Vabysmo, but we forget something about Preview. Up to now, this is, I think, the hidden thing which didn't take its own consideration and treatment of these patients. Preview is still one of the best drugs ever for drying, especially the PED and the subretinal RPE. This is we need to consider in cases which doesn't respond to faricimab and the whole thing. And I don't think this uveitis issue is a big deal, to be honest. I didn't see any case like this. But we have it here. The AMD, only anti-VEGF. So remember Preview as an alternative for these two if they didn't work in this patient. That's all.
Yeah, I think BU has fallen out of practice in our centers because of intraocular inflammations. Okay. All right. Thank you, everybody.